So if we take a little closer look at the orthopedic manifestations, this occurs due to ligament and tendon deposition, which is, again, very common in this disease. Wild-type TTR, you will see this all the time. I just want to, again, differentiate. That is not neuropathy. So a patient who has numbness and tingling in their hands from carpal tunnel or who has symptoms in their legs from lumbar spinal stenosis has those conditions. They don't have neuropathy from it, even though they are, in a sense, nerve symptoms. Those are from nerve compression as opposed to nerve infiltration with amyloid. That can happen, again, in various variant forms of the disease. So in terms of the most common orthopedic manifestations, carpal tunnel leads the way. There's a Danish registry that said there's a hazard ratio of more than 12, that if you've had carpal tunnel versus not, for later on having a diagnosis of amyloidosis. Spinal stenosis, lumbar being most common, again, is a common manifestation. Biceps tendon rupture, if it's looked for, it's been reported in as many as 33% of patients. Remarkably, many patients can have a biceps tendon rupture and actually not realize it. And then trigger finger is exceedingly common. Now, I will say, it's a pretty good physician right there. I don't know how many cardiologists are going into examining the hands for carpal tunnel and even asking those questions. And so, though these are common manifestations, I would say these will get missed all the time in a cardiologist's office unless you're really attuned to the disease. So I think the appropriate next steps, even putting the orthopedic manifestations aside, just that he's presenting with signs and symptoms concerning for heart failure, probably everybody's going to get an electrocardiogram, an echocardiogram, and a biomarker, either NT-proBNP or BNP. So let's imagine now that that's done. He has an unremarkable EKG. His echo is described as moderate concentric LVH. I put that in quotes because, of course, if it's amyloid, it's not actual hypertrophy. It's amyloid deposits causing increased wall thickness, but will often get described that way. His ejection fraction is normal, and he has a moderately elevated NT-proBNP of 1200. So I think we've probably all encountered that an answer can be, well, I've got a diagnosis for you. You have HFpEF. And I just want to emphasize that's not a diagnosis, that's a syndrome. And the question is then, what is causing the HFpEF? And one of the common mistakes is to say, well, he has a history of hypertension, that's it. He just has a hypertensive cardiomyopathy. And I suppose that could be the case, but hypertension is almost ubiquitous. About 90% of people will develop hypertension at some point in their lifetime. So, of course, there's hypertension and there's hypertension. And if he really has moderately increased wall thickness and has been running blood pressures of 140, 150, that's probably not the full explanation. And so I would almost just remove the fact that he has hypertension from your diagnostic algorithm because everybody has hypertension. And so then what are the next steps? I will often see the next step is an ischemic evaluation. I don't understand it. The ischemic evaluation would not be explaining his HFpEF, right? So I don't think, unless he has symptoms of angina, there's any role for an ischemic evaluation here. But for the reasons discussed, there's definitely a role for an amyloid evaluation. So who should be screened? So if you think about the characteristics of a good screening test, you want it to have a high prevalence of the condition in the population being screened. You want to have an accurate and preferably non-invasive test easily available. And of course, you want to be able to do something about it when a diagnosis is made. So this was one algorithm we came up with back in 2019. The exact details we could quibble over, for example, what the threshold should be of wall thickness. But the general theme, I think, still is at least as true now as it was in 2019. And so in the presence of heart failure, and you'll note not heart failure or the presence of red flag symptoms, that would be things like carpal tunnel, et cetera, and an increased wall thickness, we used 14 millimeters. Again, I think you could quibble. It should probably be a little bit less for women than for men. And the right demographics, man above 65, woman above 70. Now, again, we should probably change that for specific demographics, such as someone of sub-Saharan African descent who'd be at higher risk of having an inherited or variant form where they can present at younger age. And so at that point, you've decided to work it up. How are you going to do it? Well, step one we've already done. We've clinically suspected amyloidosis. The next step is a monoclonal protein screen for reasons we'll see. We need to rule out the possibility that he could actually have AL amyloidosis, which of course is a completely different disease with completely different treatment, and we cannot miss. So if we go to the left side of the screen now, in that case, he has a normal monoclonal protein screen. I'm going to go through what those tests are on the next slide, but let's say it's normal. Now you can move on to the test that probably most of you, if not all of you, are familiar with, and that is bone scintigraphy. In the United States, we most commonly use PYP. And if that is abnormal, we now have a diagnosis, and now all that's left to do is genetic testing to determine if he has the inherited or wild type form. If it is normal, that makes it unlikely at this point. Now, the other side of the screen, he does have an abnormal monoclonal protein. You will note that there is not bone scintigraphy on that side of the screen. There is no role for bone scintigraphy once we have shown a monoclonal protein, because now he has the possibility of AL amyloidosis. And your PYP scan can be positive or negative in AL amyloidosis, so it's no longer a useful test. So in terms of what those monoclonal protein tests are, there are ideally 3 of them. 2 are an absolute must. So what I'm going to call the SPI, which is a serum protein electrophoresis with immunofixation. What you're looking for there is whole immunoglobulins, whole antibodies in the serum, because what we're looking for is basically, does this individual have a clonal plasma cell disorder? And clonal plasma cells tend to produce 2 things: whole antibodies or immunoglobulins, and then the light chains that go along with them. But the point is, they don't always produce both of those. Sometimes it's really just the antibodies, or the light chains are in such small concentration we can't pick them up. And a lot of times, not a lot, but it happens, they will only produce the light chains and won't produce the immunoglobulins. So you need to look for evidence of both. So the serum test is looking for the whole antibodies, and you're directly looking for clonality. The urine test, the urine protein electrophoresis with immunofixation, is looking for those clonal light chains, again, directly looking for clonality. And then finally, the serum-free light chain assay. And so what you're doing here is not directly looking for clonality. You're saying everybody has a certain amount of free kappa and free lambda light chains. Those are kind of the 2 categories of light chains in their serum. And the ratio in very rough numbers is usually around 1:1. However, any of you who've done this workup have probably seen, it's not uncommon to have mild abnormalities in your serum-free light chain ratio that is normal, that is not from a clonal plasma cell disorder. The reason for that is on the bottom, that as we age and develop some kidney dysfunction, kidneys clear light chains and they clear kappa better than lambda. Kappa is produced more than lambda by the bone marrow. So what that means is that as you have worsening GFR, the ratio will start creeping up. And so it's not uncommon to have a ratio of 2, even 2.5. So if you have a mildly elevated kappa to lambda ratio, but the other 2 tests are normal, and you have some degree of kidney dysfunction, that's okay. That's not a monoclonal protein. You can still move on to your scintigraphy. Okay, so the largest study was here, over 1,200 patients at 8 centers across 5 countries, and everybody had suspected or proven cardiac amyloidosis, and they received bone scintigraphy and that exact monoclonal protein discovery that we talked about. I just want to point out here that you'll see planar imaging in that panel A. What you're looking for is the uptake of the tracer in the heart compared to the ribs. That's pretty bright, but you always need to make sure that B goes along with it, which is to say that the uptake is not in the blood pool, it's in the myocardium itself. Okay, so this is how to use the test. So in this cohort of over 1,200 patients, it got the diagnosis right in 391 out of 391 patients when you combined a positive scan and no monoclonal protein, but you need both of those things. So for this cohort, 100% specificity. Now again, the key is when you start using this in your own patients, be a little careful, make sure you're not just looking at blood pool uptake, but most importantly, make sure that monoclonal protein testing has been done. Okay, so now what? Well, let's assume that our patient here has no monoclonal protein and a positive scan. So we have made the diagnosis. He has a consistent echo and he has a consistent PYP, and he has no monoclonal protein. But we're not done, because we haven't looked at genetic testing. He definitely has ATTR cardiomyopathy. We just don't know, does he have the wild type form, the variant form? And genetic testing should really always be offered. A patient can choose to do it or not, but it should always be offered. And again, given his demographics, he has a high chance of the V122I, or what's often called V142I mutation. That's the same thing, it's just different nomenclature. So how common, how important is it? Quite actually. They are quite common and quite important. So in terms of the data, so it's pretty clear from population studies that about 3.5% of African Americans carry this mutation. So that's about 1 in 30, so quite common. But of course, that doesn't say how often it's actually disease causing. And we still don't know that answer for sure. But this was a study, 7,500 some odd self-identified black participants who were in this population-based cohort study called REGARDS. What was nice about it was they had genetic data available, and nobody here had baseline heart failure. And then they were followed for many years. Again, you see minimum of 11 years up to more than that. And so the results over that time was that just carrying this mutation, that's the only variable we're looking at, a hazard ratio for incident heart failure of almost 2.5, for heart failure death over 4, and even all-cause mortality, a hazard ratio of 1.46 simply by having this mutation. This is looking at the y-axis as the cumulative incidence of heart failure, the x-axis is age. Again, look at the difference, particularly once you hit age 70, but I would emphasize people can start developing symptoms before that for sure. But in the population database, it really takes off when you get to about age 70 among carriers versus non-carriers. Okay, so in this patient, the next step is that he has his genetic testing performed. He has this mutation in the heterozygous form, which is the more common form we'll see, of course. So we now have a diagnosis of variant or hereditary ATTR cardiomyopathy. So now it is time for treatment. As hopefully most of you know, the sooner we initiate this, the better. So let's see how the case unfolds.
Hi, James. It's nice to meet you. How are you feeling today?
Well, I've been feeling worse over time. I'm getting out of breath more often, and I notice my feet and my ankles are swollen more too. My wife and I are pretty worried about this.
I understand your concerns. I've looked over your records and your recent test results from your primary doctor. Why don't we go over the results together?
Yes, please. I'm really anxious to know what's going on.
Your echocardiogram showed that your heart muscle appears thicker and stiffer than normal. And this is being caused by a condition called hereditary cardiac amyloidosis.
So I do have that amyloid thing that my doctor mentioned. What exactly is that again?
Yes, you do. Cardiac amyloidosis is when an amyloid protein called TTR misfolds and deposits in your heart, causing heart failure. The TTR can also deposit in other organs and tissues. Now, I saw it noted that you have back pain and possible carpal tunnel syndrome.
Yeah, I've been living with pain and numbness in my back and wrists for a while.
Yeah, these symptoms may also be from the misfolded amyloid TTR in your ligaments and tendons. And we'll know if they improve when we treat the amyloidosis.
Okay, that makes sense.
Now, are you having any new symptoms since you last saw your primary care physician?
Well, I'm not sure if I'm imagining it, but I swear my feet feel numb now. Even when I'm not having swelling, it's almost like it's like a burning feeling.
Sounds like you may be having something called neuropathy. It's a numbness or a burning sensation in your hands and feet, and it can also be a symptom of amyloidosis.
I see, so, you said this amyloidosis is hereditary, but I don't know anyone else in my family who has it.
Another reason we know it's hereditary is because you were tested for a gene mutation that's common in African American people with amyloidosis. It's called the V122I mutation, and the test shows that you do have that mutation.
Okay, I see. So what does that mean?
Well, genetic testing is important for a few reasons. First, it confirms the type of amyloidosis you have, which can help us choose an appropriate treatment. It also makes us aware that it can run in your family. So any first-degree relatives you may have, like siblings or children, should be tested for the mutation. Now, if they have the mutation, it doesn't automatically mean they will get amyloidosis, but knowing they have the mutation can potentially allow early diagnosis and treatment if they do get symptoms.
Okay. So I guess I will need to tell my brother and my son to get tested.
Yes, and we can refer you to a genetic counselor who can go over all of this with you in more detail so you fully understand what this means for you and your family.
Okay. That would be really helpful.
Now lastly, the hereditary form of cardiac amyloidosis tends to be more aggressive, so it's important for us to move quickly to start you on treatment.
Are there medicines for this?
Yes. Yeah, the good news is we have a few effective treatment options now. And the earlier you start treatment, the more effective the treatment can be.
Okay, good.
Now, James, it's important to know that the available treatments won't cure or reverse the disease, but they can slow its progression, and many people feel a lot better after starting treatment.
Okay. How can I learn more about the treatments?
So we've seen escalating symptoms and how the scene is evolving, how the conversation is going on with the patients who's now understanding where the symptoms are coming from, but also from coming to the clinic with just a bit of shortness of breath, peripheral edema, has now been given a diagnosis which is specific, for which there are specific treatment, but at the same time, this has got consequences for the whole family. So the psychological burden, not just for the patient, but for the whole family, at this point has to be managed. So, but let's start with a question. When should the patient be reevaluated to confirm the diagnosis? Is it in a month, in 2 months, in 3 months, in 6 months? So you have seen how we go from the clinical suspicion, so patients presenting with heart failure symptoms, but a series of red flags, which go from the clinical history to the physical examination, but also to the finding on the test, ECG, the echocardiogram, and again, getting back that into the clinical history. So we can suspect cardiac amyloidosis, then if we suspect ATTR, you've seen there are a series of investigations that we need to do, but this is a multi-step process, which has got the key steps, bone scintigraphy and a plasma cell dyscrasia. In some of the patients then involve also histology and definitely genetic testing. But what we see very commonly is that this process can take a month in some of the center, but it can take 6 to 12 months. And what we have all been trained on as physicians is that cardiac AL amyloidosis, which is the other form of amyloidosis, is a medical emergency. So we've been trained to think if you suspect ATTR amyloidosis, you have to get diagnosis within a month, because a month in delay in the diagnosis is associated with worse prognosis. But at the same time, this kind of translated in, oh, ATTR amyloidosis, you just got more time. You just can take a bit more time to get their diagnosis. But is this really the current approach we should have to these patients? So I'm pleased to say that 50% of you responded less than a month, and so 12% 2 months, but still we have 20% respond in 6 months. Is 6 months really an acceptable delay from suspicion to diagnosis in these patients? What we've clearly seen from the 3 major trials that have been done cardiac ATTR amyloidosis is that what patients lose in the double-blind phase is not really gained back when they go on to active treatment. And at the same time, you heard from the scene, the clinical scene, that one of the comments from the physician was, it's important to start treatment as soon as possible because we are all aware that treatment-modifying treatment works best if started as soon as possible in the disease course. So it's extremely different to say 3 months, 2 months, a month, but I would say definitely 6 months is too long for these patients to be starting disease-modifying treatment, and in most cases 1 to 2 months is an acceptable kind of time frame to go from suspicion to confirm the diagnosis. So you have seen how we discussed that from 2016, the diagnostic approach has completely changed. We diagnose 70–80% of our patients non-invasively. But at the same time, what I've seen in my institution, and I've heard a similar comment to the colleagues, is that we've gone from 2016 onwards to diagnosing more and more patients non-invasively, but now also we recognize the importance of getting a biopsy whenever there is a plasma cell dyscrasia, whenever things quite don't fit. Because the different type of amyloidosis got completely different treatment. If there is any suspicion that something doesn't fit, or if there is a plasma cell dyscrasia, then the possibility of AL is real, we should proceed with a biopsy. And that, of course, would lengthen slightly the diagnostic process, but getting the right diagnosis is the most important step to improve the patient prognosis. So let's go back to the case. So we've been talking about 60-year-old men with hereditary ATTR amyloidosis associated with the mutation V122I, we said V142I, confirmed by the genetic testing. So first of all, I would just like to say, this patient happens to be a man, but ATTR's cardiomyopathy can also be diagnosed in women. At present, the proportion is only 10% versus 90%. The vast majority of our patients are men, but we are fully aware that this is probably not a real biological differences, but unconscious bias is playing a massive role in us as physicians in suspected diagnosis of ATTR amyloidosis much more in men than women. So this patient could have been a female as well. So the patient, 6 months, had progressive breathlessness and edema without prior evaluation, and new symptoms of neuropathy. So you heard burning and numbness in the feet. And also, the diagnosis of V122I is opening kind of a new problem, so the implication for the rest of the family. So it's not just a new diagnosis for the patients, but 50% of the children could be carriers of the V122I mutation, and also 50% of the siblings. Having the mutation doesn't mean that patients will go and develop the disease. We know that the penetrance of V122I mutation is extremely variable, and this means that having the mutations would translate into disease in some, but could also never translate into the disease in some other patients. And an important risk factor is actually the family history. So having a patient with V122I, but who has got history of ATTR amyloidosis increases the risk compared to a patient with a V122I mutations with no family history of cardiac amyloidosis. So in this case, it's absolutely important to do cascade screening to test the family members. But also I find interesting how these approaches change over time. 13 years ago, when I started working in this field, we wouldn't really do cascade screening because we had no treatment. So there was absolutely no point in making a diagnosis of diagnosing young carriers with a V122I mutation and other mutations and saying, we can follow you up, but whatever happens, there is nothing we can do. So doing genetic testing cascade was a very controversial topic, and it wasn't quite clear what we have to do. But now that we have disease-modifying treatment, the approach has completely changed. It's absolutely mandatory not to stop at the single patient, but talk with the rest of the family. And genetic counseling has got extremely important role. The psychological implication for younger individual carrier of a mutation has got implications psychological, legal, insurance, and so depending on different country and different legislation, but the implications are much wider than what we may think as physicians communicating the diagnosis to a patient. So 6 months delay between primary care and suspicion and diagnosis is definitely too long. And ATTR amyloidosis is a progressive disease, and we are absolutely certain that early diagnosis translates in better outcome, because if we start disease-modifying treatment early on, this will be the patient that will have a better prognosis. And you've seen how suspecting ATTR amyloidosis, the clinical history and the red flags that Ron has gone through are absolutely key. Bilateral carpal tunnel is almost invariably present in our patients. Spinal stenosis, back pain. So when an 85 comes with back pain, think a bit more. It's very common, but actually spinal stenosis is quite different from the usual back pain. As Ron said, the bicep tendon rupture is much more common than what we think. History of hypertension, but actually the patient is hypotensive. And then this discrepancy between the findings on imaging ECG and the history of hypertension, for example, 20 millimeter wall thickness, but actually no evidence of good going hypertension, low voltage in the EKG, and actually normal echo. So there are a series of red flags that can raise a suspicion of amyloidosis, and then you've seen how a combination of bone scintigraphy and plasma cell dyscrasia testing, i.e. free light chains, blood and urine immunofixation allows us to make a diagnosis in 80% of the patient without the need of an biopsy. But every single center needs to be prepared to go for a biopsy in the 20% of the patients where there is a plasma cell dyscrasia. And why is that? A positive DPD scan doesn't equal ATTR amyloidosis. A positive DPD scan could also be AL. 50% of the patients with cardiac AL amyloidosis have got a degree of cardiac uptake. And also no uptake on DPD scan does not equal no amyloidosis. 50% of the patients with the cardiac AL amyloidosis will not have any uptake. So it's absolutely essential to do all the steps of the way of the diagnostic pathway. So if we suspect ATTR amyloidosis for lots of different reasons, bone scan, and we've seen how SPECT-CT is absolutely important, is an essential requirement. Planar imaging is not optional. Planar imaging is not fine alone. And plasma cell dyscrasia, which include free light chains, blood and urine immunofixation. And I would say, as cardiology, electrophoresis is not enough. If we don't do immunofixation, we will miss roughly 2.5% of patients with AL amyloidosis. Most cardiologists don't know the difference between electrophoresis and immunofixation. I didn't know electrophoresis and immunofixation before getting into amyloid. Immunofixation is an extremely more sensitive test to detect any evidence of a plasma cell dyscrasia. And genetic testing is mandatory in all patients. So refer promptly to amyloidosis cardiomyopathy specialist with an ideal timeline evaluation within 4 to 6 weeks from initial suspicion. But one of the questions, like you've seen the patient's binding cessation in the faint numbness, I would say that this is more typical of neuropathy, but as Ron said, this patient have got also spinal stenosis. So spinal stenosis and carpal tunnel syndrome can give symptoms like numbness in the feet, the tip of the fingers, pins and needles, but also in the hands, but also numbness in the feet, which could mimic neuropathy. So a formal neurological assessment is absolutely key to distinguish carpal tunnel, lumbar spinal stenosis from neuropathy. And why is that? Because disease-modifying treatment options are different in patients with cardiomyopathy compared to patients with clinical phenotype. But let's assume that these patients had neuropathy. So neuropathy is not an uncommon manifestation in patients with a hereditary ATTR cardiomyopathy associated with the V122I mutation. If you ask your neurologist to screen for neuropathy, it can be present in up to 50% of the patients. And typically the patients complain of numbness, which starts from the sole of the feet or from the tip of the toes, because it's an axonal length-dependent peripheral neuropathy. So this is kind of how neurologists describe it, but as a kind of simple cardiologist, the way I think about it is because it's axonal dependent, so it's length dependent. It starts from kind of the most distant part of the body, so the bottom of the feet, the tip of the toes, and then progresses proximally. And as a neurologist, as a cardiologist, what I simply ask is, where is your neuropathy now? And patients are actually very accurate in saying, oh, it's been stable, it's still like here, or it's just below my knee. And actually, by asking simple questions about peripheral neuropathy and autonomic dysfunction, can you get an idea of how the patient is, at what stage of disease progression, and how the progression is. So neuropathy may appear before or after the patient's symptoms, and is extremely variable depending on the mutation. So the co-presence of neuropathy and cardiomyopathy depends on the mutation, and that's why the genetic testing is so important. It's important for the family, but it's important also to understand the clinical phenotype for the patients and what to expect also in terms of natural history. And also it's important to assess the multisystemic involvement, neurology and autonomic testing. So autonomic testing is something that we tend not to pay a lot of attention to, but has got a massive impact on the quality of life. So these patients extremely commonly manifest GI symptoms. So it can go from extreme autonomic dysfunction, where the patients have got terrible diarrhea, alternating with terrible constipations. And when I say terrible diarrhea, patients cannot get out of the house for 1 or 2 weeks when the diarrhea comes along. And then they go into a month of terrible constipation, and this is when the autonomic dysfunction is really extreme. They can have a postural drop of 60 millimeters of mercury in blood pressure. They can have multiple blackouts in a month because of the postural drop. But also we have milder form of autonomic dysfunction. Then while they're much milder than these, they do affect significantly the quality of life. So GI symptoms with patients feel bloated, difficult digestion, are not uncommon and are just part of the multisystemic involvement. So the V122I mutations identify the patients as having hereditary disease, so we need to offer first degree relatives should be off cascade screening testing. And as I said, this approach has completely changed 10 years ago to now, because now we have disease-modifying treatment that should be started early on in the disease. And one of the things that I try to communicate to patients, I understand that this will come as a shock for the rest of your family, but if we screen them early, they will never get to the stage where you are now. We can catch diseases early and prevent disease evolution. And so we need to, genetic testing where we clarify the inheritance risk, guide family communications, and provide emotional and psychological support is absolutely essential. And really also communicate positively that, yes, whilst there are family implications, early identification in the family members will completely change the life. And the goal of the treatment is really to slow or halt disease progression. But we were discussing yesterday how we are really moving on thinking, if I see a patient, if I would see a family members of this individual with ATTR cardiomyopathy but not symptomatic yet, this is a patient where actually now proactively, most of us are very happy to start disease-modifying treatment and prevent development of heart failure symptoms in a patient with full-blown cardiomyopathy. So genetic screening of the family could make a massive difference for many patients. And what are the treatment? We've got 3 disease-modifying treatment in the field, extremely effective that we can discuss with the patients. 2 follow in the class of stabilizers, so the protein is produced, but what happens is it's stabilized in the tetrameric conformation, so in the native conformation. But the stabilization in the native conformation reduces the new amyloid production and so delay disease progression. The 3rd drug falls within the class of gene silencers. So the protein is targeted as source from the liver, and so the gene is silenced and there is a reduction in the protein production from the liver. How do we choose, and this is the question that I get all the time after any talks from anyone, what is your first line and second line, is really a shared decision making with the patients. We are very fortunate as physicians working in the field because we've got 3 disease-modifying treatment options which are effective. There are no head-to-head comparisons, so we cannot say one is more effective than the other one, but the good news for patients is that there are 3 very effective disease-modifying treatment that have been shown to improve mortality, cardiovascular-related hospitalization, functional capacity, and quality of life. And so the therapy of choices should really be guided by, of course, availability and tolerability, but also preferences of the patients, 1 pill a day versus subcutaneous injection, mechanism of action. So discussion with patients, and my experience that actually patients have got often much more to say about what they want compared to what we think they want. And, but the kind of common ground to all this treatment is all require early initiation for the maximal benefit. So when we integrate the discussion back to the patient, so James then was started on a ATTR-specific therapy, improved functional status and stability for a couple of years. So improvement versus stability in the sense is dependent on disease stage, dependent also on the addition of other treatment, because in this patient we should not start just disease-modifying treatment which target the amyloid production, but we should also start heart failure medications. Most of us would agree that these patients we should probably start an SGLT2 inhibitor, which is extremely effective in managing breathlessness in these patients, brings about improvement in many of these patients, and also MRAs. And as I said, some of the patients will be stable, some of the patients will improve, but also we'll have also some of the patients who will continue to have some mild degree of progression. But now age 68 with NYHA class 3 symptoms, and the patients present with new onset atrial fibrillation, which is an extremely common occurrence in patients with this condition. The atria gets infiltrated as much as the ventricle, so there is an atrial myopathy, not only a cardiomyopathy, and so the patient is presenting back with atrial fibrillation, worsening the symptoms, and managing heart failure therapy, a rhythm-related complication, is equally important as managing the patients with disease-modifying treatment. So let's see how these new symptoms are now addressed. So I would say the key takeaways from scene 2 is that early suspicion and prompt diagnosis is the key. 6 months is too long to make a diagnosis. I would say that probably a couple of months to 3 months is a reasonable time frame to get from suspicion to start of the treatment. Neuropathy is part of the spectrum in many patients. Up to 50% of Afro-Caribbean patients do have neuropathy, and it's important to differentiate mixed phenotype from cardiomyopathy because there are different disease-modifying treatment. Genetic counseling is mandatory in all the patients before and after testing, and multiple effective treatments are now available, and initiating this treatment as soon as possible is the best thing we can do to improve the prognosis in our patients. But then let's go back to the clinical scene.
So I see you were hospitalized last month with a heart failure episode. How have you been feeling since then?
Well, I hate to say it, but I'm not doing as well as I was. Even with the higher dose of the water pills, I'm still getting winded. Just walking from the bedroom to the bathroom. Also, my legs and feet are swollen a lot more often.
I see. I also see that your NT-proBNP level has increased by almost 100%. Now, you've been stable on your ATTR treatments for about 2 years now, so this is concerning. Are you experiencing any other symptoms like chest pain or irregular heartbeats?
Actually, yes. During my hospital stay, they said something about my heart rhythm being off. Atrial something.
Atrial fibrillation,
yeah.
or AFib for short. Now, I see that your records from the hospital show that, and that that is a brand new symptom for you.
Yeah, yes, that's it, AFib. And I've just been feeling so tired and run down since that started.
Well, it's very common to feel unwell when your heart is not in a normal rhythm. Plus, the heart failure symptoms, more fluid retention, and worsening shortness of breath are signs that your cardiac amyloidosis may be progressing.
I was afraid of that, but I thought the amyloidosis medication was supposed to stop that.
Well, ATTR treatment can slow progression, but unfortunately, it doesn't stop it entirely.
Okay. So how do we know if the amyloidosis is getting worse?
Well, when looking for progression, we first and foremost want to know how you're feeling, which you've not been feeling well. Then we look at your heart failure symptoms, which your swelling and shortness of breath are getting worse despite increased diuretic treatment. And you have new symptoms, like AFib. And then we look at your biomarkers like NT-proBNP, which again, your level has increased. So putting all of that together, I'm highly suspicious that your amyloidosis has progressed.
Okay, so what can we do?
Well, what's important now is that we're catching all of these changes and we can adjust to our management approach. I'd like to monitor your heart rhythm more closely and talk about some options to get your heart back in rhythm.
Okay, and what about my amyloidosis treatment? I've been doing some reading online and I know there are a few ATTR treatments available now. Is what I'm on still okay, or should I switch to something else?
That's an excellent question, and exactly what we need to talk about next.
Okay, so what we can see from that last scene is the patient's been on ATTR therapy for a period of time now, and clinically has some signs of worsening with atrial fibrillation, more breathlessness. And I think now that we have multiple ATTR therapies, we're diagnosing people and managing them longitudinally, some of the questions that are coming up are how do we assess patients over time, and how do we make adjustments to different parts of their management depending on how they present to us. So for the polling question, let's see what everyone thinks. Which of the following is not a biomarker of ATTR disease progression? 1, C-reactive protein, 2, EGFR, 3, NT-proBNP, or for troponin. So it looks like we have a range of responses, but the majority of people say that C-reactive protein, or CRP, is not a biomarker ATTR disease progression. And then there's a few for the other ones. So we'll go over some of this on the subsequent slides. So just to recap, so 2 years after starting ATTR-targeted treatment, James has now had a recent heart failure hospitalization. Has had some worsening symptoms, such as dyspnea, edema, and fatigue, and is recently diagnosed with atrial fibrillation. So how do we recognize or describe disease progression? I'll just say up front that this is something where we're actively studying, and there's not a one-size-fits-all definition. This is going to be defined, somewhat from research parameters, but also how we approach these patients clinically. But some of the things that we can look at and consider when we're assessing the patient are things like cardiac biomarkers. NT-proBNP and troponin are not specific biomarkers to ATTR, but are things that worsen with various cardiac conditions, heart failure, as well as new onset atrial arrhythmias. Oral diuretic intensification, so this is when patients need escalating doses of their often loop diuretics to manage their heart failure. I think clinically this is an important sign of identifying patients that are having worsening in their diastolic dysfunction, perhaps developing some degree of cardiorenal syndrome, which can be a sign of more advanced disease. And then I think that, as clinicians, we look very closely at how the patient's feeling. I mean, they can, you ask someone, how do you feel compared to 6 months ago, 12 years ago? People are usually pretty articulate about reflecting on how they've been doing physically, and can usually anchor on things that they could have done, say last Christmas or last holidays, and what they're able to do now. And so I think that that's really important, not necessarily quantifiable information, but really gives you a sense of the patient's overall trajectory. Very concerning when patients have heart failure hospitalizations, particularly recurrent hospitalizations. In heart failure in general, we know that this is a poor prognostic sign. When we think about advanced therapies in the general heart failure patient, we know that once someone's had 2 heart failure hospitalizations within a year, that portends to a much worse prognosis. And in certain populations, we would think about advanced therapies like transplant. I think that sometimes this gets overlooked because patients come in with decompensation, they get diuresed, they feel better initially, but there's an overall downward trend once you start to see these recurrent hospitalizations, and so that should prompt clinicians to think about adjustments that can be made to their management. And then concomitant conditions such as atrial fibrillation and conduction disease, which are other manifestations of amyloidosis, are important to assess. So in terms of biomarker assessment of ATTR amyloidosis, this was a nice study performed by Dr. Fontana as well as colleagues in the external validation cohort, looking at worsening NT-proBNP and outpatient diuretic intensification as markers for disease progression in ATTR cardiomyopathy. And so what you can see in the NAT cohort as well as the external validation cohort is if you have worsening in your NT-proBNP, so an increase of 700 nanograms per liter, along with a 30% increase overall in the absolute number for NT-proBNP, that's concerning from a prognostic standpoint. And combining that with oral diuretic intensification, that group is the highest risk when you have both of those features. And I think, this reflects the worsening heart failure and somewhat, the drivers of things like cardiorenal syndrome. And so I think it's, one piece of the puzzle for helping us kind of objectively think about patients that we should watch, follow a little bit more closely and make sure we're optimizing the components of their management. So we've heard about atrial fibrillation in this patient, and my colleagues have mentioned this as well. Atrial fibrillation is quite common in ATTR-CM patients. A number of observational studies come out with a number around 70%, give or take. So it's something that many patients with ATTR will encounter at some point. I would say the timing of atrial fibrillation, just to kind of clarify, is not always after heart failure, developing heart failure. A lot of times patients may have atrial fibrillation months to years before they have heart failure. So there's not kind of a linear progression of heart failure and atrial fibrillation that can kind of occur throughout the course of their disease. It's associated with atrial remodeling, so there's direct amyloid infiltration into the atrium. And when you have concomitant atrial fibrillation, that can exacerbate heart failure symptoms. So a relatively stable ATTR patient could have developed worsening functional status with acute episodes of atrial fibrillation. There's also increased thromboembolic risk in these patients. And some of that has to do with the fact that there's a mechanical stiffening of the atria. So even when patients aren't in atrial fibrillation, they can have a heightened risk of thromboembolism. Anticoagulation is really important, particularly in the ATTR-CM patients. Traditional risk stratifications such as CHADS, FAST2 don't take into consideration some of the increased risk associated with amyloidosis. And in terms of how we manage atrial fibrillation, I would say that in recent years we're more aggressive about pursuing rhythm control in patients. I think that the dogma historically is that these patients, because of all the amyloid infiltration, are less likely to respond to things like atrial fibrillation ablations or antiarrhythmics. But particularly as we start to diagnose people earlier, many patients can have a durable or clinically meaningful response to rhythm control. And so I think it's reasonable, particularly for new onset atrial fibrillation, to pursue that and see what clinical response you get. Noted that definitely when the patient has more advanced disease, they're less likely to maintain sinus, but I think in many individuals now it makes sense to attempt rhythm control. So when assessing patients that are having worsening symptoms, worsening functional status, what are some of the things to think through? Of course, are they adhering to their medication regimen, not only their disease-modifying therapies, but the other heart failure therapies, having access to these therapies. And then in terms of therapeutic options, so we can talk about this in the Q&A as well, but I think that, and we'll see kind of on some later slides, to date we don't have definitive data to help guide us for things like combination therapy and switching therapy. So I'm not going to touch too much on that. But when we look at by patient basis, knowing their amyloid subtype, so is it hereditary versus wild type, is there a degree of neuropathy is a consideration. Of course, if they have side effects on therapies, then that should also come into play. But I think we really want to emphasize the importance of the non-disease modifying therapies for ATTR. I think that that's oftentimes where we can intervene and improve patient symptoms and functional status. Many times they can be under-diuresed. I think when we see patients referred to us, one of the first things that we do, is to make sure that they're on a good diuretic regimen, because that's the thing that if they are under-diuresed can make them feel better pretty quickly in the short term. We've talked about considering rhythm control for atrial fibrillation, and then the role for heart failure therapies such as SGLT2 inhibitors have become very common in our practice. And in other patients, we think about mineralocorticoid antagonists as well. And because these patients have a systemic disease, it's really important to have input from not only the cardiologist, but other stakeholder specialists such as neurologists if patients have signs of disease in those areas. And our heart failure nurse coordinators are really key components to our team in terms of making sure that patients can navigate this complex care. So in the next several slides, we'll talk about ATTR therapies, and it's important to review the mechanism of action because that'll help us to understand how these therapies work. So the majority of transthyretin is produced in the liver. It functions to transport thyroid hormone and vitamin A throughout the body. It's secreted as a homotetramer, so that's 4 subunits of protein that are closely bound together. And what happens in individuals that develop ATTR amyloidosis is that these tetramers have a propensity for dissociating into monomers. These monomers are thermodynamically unstable and have an increased likelihood of misfolding. And when these monomers misfold, they become sticky and start to aggregate and become the protofibrils that go on to develop into mature amyloid fibrils, and that's what deposits in the heart and other places. So the 2 medications shown here, tafamidis and acoramidis, we heard are transthyretin stabilizers. These are small molecules that bind to that tetramer to help decrease the amount that dissociates into the monomer. The tetramer dissociation is really that first rate-limiting step in the amyloid dissociation process. And so these small molecules slow that dissociate or minimize that dissociation. So what are the studies that support use of these therapies? Shown here is the ATTR-ACT study, and this looked at tafamidis. This looked at patients with wild-type or variant ATTR and randomized them to tafamidis versus placebo and followed patients out to 30 months. I think that what's striking, this was the first pivotal phase 3 study in the field, showed very strong benefit for survival, as well as improving things like 6-minute walk and KCCQ compared to placebo. And this led to the approval of the first therapy for this disease, and it's relatively recent. So we went from a period of just heart failure management and symptom management to disease-modifying therapy that has benefits in helping patients to stabilize functional status as much as possible and also improve their long-term survival. For acoramidis, that was studied in the ATTRibute-CM study, pretty similar design and patient population study. And you can see here from the outcomes that there is a benefit for survival as well as biomarkers and functional status. You can see that on the bottom right that there's a change in serum TTR. So we know that when patients are treated with stabilizers, their serum TTR levels increase and probably reflects some degree of stabilization of that protein, leading to less breakdown. And so with stabilizers, we see kind of a rapid increase in the prealbumin or transthyretin level that's sustained once you start treatment. So what about the third medication that we saw? So this class of medications are known as TTR silencers or knockdown agents. These reduce the protein production of transthyretin in the liver. This can be done through a couple of mechanisms of action, or a few mechanisms of action, but specifically for vutrisiran, this is an siRNA, so small interfering RNA, that decreases the RNA transcript that goes on to make the TTR protein. So if you're making less TTR protein, there's less that can go on to form those toxic monomers that misfold and aggregate. So vutrisiran was studied in the HELIOS-B study. And this looked at patients, again, with wild-type or hereditary ATTR. And we can see here through 36-month follow-up is a statistically significant benefit in all-cause mortality or first CV event. We see that 6-minute walk is better in the treatment group as well as KCCQ. So also strong data for this disease-modifying therapy. So in this slide, just want to highlight what the progression of outcomes in patients with ATTR-CM are. These trials were done in somewhat different eras of patients. So at the time of the ATTR-ACT study, when there were no treatments, the tendency was to diagnose patients with more advanced disease. You can see here that the outcomes are worse for both the placebo group and the treated group, just reflecting kind of the overall sicker population of patients. But as we use more non-invasive testing, so the bone scintigraphy scans, more awareness of this disease, we're capturing patients earlier. There's still a lot of work to do to capture patients even earlier, but the general trend is that we're seeing patients with earlier disease, better outcomes. And so I think that that's important, particularly when people think about how to look at the data across trials. These patient populations are just inherently different in terms of their overall disease stage and comorbidities. So these are just some data from the HELIOS-B study showing a pooled analysis of safety. The stabilizers as well as vutrisiran overall very safe and well tolerated by patients, which I think is very important to highlight, particularly as patients are on these over extended periods of time. So I think when choosing therapies, there's some practical things like assessing the patient phenotype. Do they have cardiac disease or mixed disease, comorbidities, patient preference. The medications in terms of administration, both tafamidis and acoramidis are oral medications, and vutrisiran is a subcutaneous medication given every 3 months. It's important to, I think, get patient input in terms of what their preferences are, and that's, I think, a big component of treatment selection. So these are kind of in-press or hot-off-the-press guidelines from the ACC Consensus Group for Management of ATTR-CM. I'll just highlight here kind of what the general consensus is for managing patients at different disease stages. So individuals who are found to have a TTR mutation, oftentimes through cascade testing, but are asymptomatic and have no evidence of amyloid on cardiac testing, There's currently no data to support treating those patients prophylactically. The penetrance of these variants is incomplete, so not necessarily every patient that has a variant will go on to develop disease. It's an important question about how to monitor these patients, and would there be a benefit for preventive therapy? There's a clinical trial called ACT Early that's ongoing, looking at acoramidis versus placebo in this population, which will hopefully give us some more information about the role or not for treatment in asymptomatic carriers. For patients who do have confirmed ATTR-CM, that's where we have robust clinical evidence for disease-modifying therapy supported by those 3 trials that we've reviewed. So if you have a patient with clinical ATTR cardiomyopathy, class 1 to 3 heart failure, then we want to pursue a disease-modifying therapy, as well as manage their heart failure. And like I said, diuretics, SGLT2 inhibitors, and MRAs are important components to patient management. Being thoughtful about management of atrial fibrillation, considering rhythm control, having a low threshold to treat with anticoagulation, or I guess a high threshold to not treat, you'd have to have a high bar not to treat with anticoagulation. And then if a patient has a mixed phenotype, then with vutrisiran, there's data for both cardiomyopathy as well as neuropathy, so that might be consideration for using vutrisiran in that scenario. But for cardiomyopathy patients, we have several options: tafamidis, acoramidis, and vutrisiran. And patient preference and access are going to be important components of treatment selection. And then patients who have more advanced disease, class 4 heart failure, significant renal dysfunction, significant functional impairment, that's where we have less data about these therapies. They work much better for earlier stage disease, and their role for these more advanced patients is something we need more information in. And depending on the patient population, thinking about things like advanced therapies such as transplant should be considered. So in terms of monitoring response over time, these are some of the things to think through: clinical symptoms, functional assessments, biomarkers. On imaging, there's things that we can follow, but there's nothing clinically that's been robustly validated. And in terms of the frequency of monitoring and follow-up, I think it really just depends on the patient. The patients that have active heart failure medication titration, you might see more frequently, every 3 months. But if someone is relatively stable, then you can space that follow-up to 6 to 12 months. And for a lot of these patients, they might be co-managed at an amyloid center in a local practice, and so that also plays into how frequently they should be monitored. So, shared decision-making is extremely important in really navigating this with patients in terms of treatment goals, what to expect from a symptom standpoint, risk-benefit for various therapies. And it's really important to engage both the patient and family members, like we discussed. So some of the key takeaways are that if a patient has worsening heart failure symptoms, worsening biomarkers, it's probably consistent with progression, but with the caveats we mentioned. Atrial fibrillation is quite common, and so they should be on anticoagulation, and rhythm control should be considered. And then in terms of therapies, both stabilizers and silencers are highly effective, work through different mechanisms, and some of the decisions around treatment selection are really case by case and made in joint conjunction with patients. So just a couple of quick highlights on ATTR clinical practice, and then we'll hear some quick takes from Dr. Fontana and Dr. Witteles. So these were in the ACC consensus guidelines. I think just kind of an overview of where we are in the field and where the unanswered questions are. So we know that there's certain at-risk groups that we should probably focus our screening on. So those patients with increased left ventricular wall thickness, abnormal strain on imaging, and then HFpEF and aortic stenosis populations are enriched for ATTR patients. And if they have some of the extra cardiac manifestations that Ron went over, that should also increase suspicion. We heard about how to do the diagnostic workup for these patients, and monoclonal gammopathy rule-out is not optional and really will guide the downstream testing, whether you can diagnose patients non-invasively or need to pursue a biopsy. Heart failure management, I think, is equally important to the disease-modifying therapy that you use. And so oftentimes the heart failure therapies will be the things that help patients feel better in the short term, and with the disease-modifying therapies, you're hoping to stabilize patients in the long term. And then unanswered questions or areas where we need more data, particularly real-world evidence generation, would be the role of combinations of therapies or specific therapies for specific subgroups. These are ongoing areas of investigation. How some of the novel mechanism of actions will play in this, so like the depleters that are being studied in clinical trials now will be things that we need further data on. So just finally, some information about the three therapies that we've talked about. So we have tafamidis, it's a transthyretin stabilizer. It's given once a day, and it's FDA approved for ATTR cardiomyopathy for wild type or hereditary. Acoramidis is also a stabilizer that has indications in the same populations. It's a twice-a-day medication. And then vutrisiran is a gene silencer siRNA that's been studied in both neuropathy and cardiomyopathy and has indications for both. And it's a subcutaneous injection given every 3 months. So with that, I'll turn it over to Ron for some quick takes.
Great, thank you. So the first quick take, again, is to really have systematic early recognition for those red flags and referral triggers. I just want to emphasize, because we talked a lot about red flags, and you'll see these long lists, that the core red flags are very simple. The age range we talked about, and again, we can think about that for sex-specific, and similarly, increased wall thickness, again, can think about it for sex-specific. If you see a thick heart in the right demographics, that should be all it takes. But the other red flags will make it just even more that much more likely. So again, an individual of sub-Saharan African descent, orthopedic manifestations, chronic troponin elevations, which are very common in the high sensitivity troponin era. I put an asterisk about a lack of LVH on EKG. So many people are familiar with the low voltage concept of EKG equals amyloidosis. Certainly, if you see, frankly, low voltages, that raises the likelihood, but just seeing normal voltages with a very thick heart is also abnormal. That should be a red flag. Heart block, again, is very common. We've talked about atrial fibrillation. It's more common than not in amyloidosis patients. Neuropathy, but again, that would be specifically for variant patients, which are still the minority of patients with this disease. And finally, suspicious family history, but again, that's one of those things that if present should make you worry about it even more, but most patients will not have that. Now we'll move to Dr. Fontana for the second quick take.
So again, quick take on systematizing early recognition. No,
I think you have. Yep.
I think
you've gone
back.
There we go.
So quick take on how do we do genetic counseling and family outreach. So up to 15 to 20% of patients with ATTR-CM have got hereditary ATTR amyloidosis, and as we said, identifying the variants of V122I, like in this case, other variant, clarifies the diagnosis and the clinical phenotype to expect in the patient. So as soon as we know the variant, we know the spectrum of disease that the patient could develop over time. And of course, it gives also important information on prognosis of the patients, because the degree of cardiac involvement versus the degree of neuropathy, which differentially affect the prognosis and then quality of life. But importantly, as we discuss, enables cascade screening of first degree relatives. Age of the relatives is an important factor. We don't advise to screen all relatives at any age, but what we most of us do is that we tend to screen relatives from 10 years before what the clinical presentation of that mutation be, and why that is the reason. There's no reason to screen the family members of 20-year-old family members of V122I mutations, because we know nothing is going to happen until at least the 40s. But screening a family member at 20 will have massive psychological implications for the patient, so it's absolutely important to take into account the age of the presentation of the specific mutation, and then it takes the age at which we consider screening of the family members. And then genetic counseling is absolutely essential, not just before, but also after, to manage the impact that having a variant had on all patients. So from gene to family, how do we do it? So referral diagnosis to certified genetic counselors. So we need people who are competent in giving the right information to patients and explaining the phenotype, the specific mutations, the implication on the quality of life and the prognosis. It's absolutely key, provide plain language family letters. So how do we capture all the family members? So we need to have kind of information that we can give to the patient to distribute to the family members that then they can reach if they want and have further information. We need to partner with community clinicians for local testing. That would be ideal, but also what now is available in many centers is actually video consultations, and then the saliva test is just sent out and then sent back. So at this stage, patients do not need to come to the clinic. The simple gene testing can be done just by counseling over a video consultation, send the saliva testing kit, and the kit gets sent back, and so then is communicated in a second consultation. Again, virtual counseling is really becoming increasingly important in this patient population. And importantly, record and follow through who has been contacted, tested, and also just not stop at the first attempt. Some of the patients at some point in their lives might not be in the right place to have the testing done, but a couple of years after, this could be very different. So.
Okay, so moving on to real-world monitoring. So start with a provocative question. Is there any role for monitoring? Not totally clear. The answer is yes. Of course, you're going to be monitoring your patients and you're going to be adjusting your patient's therapies. But we still don't know, okay, your patient has quote-unquote progressed. What should you do about it? And we don't actually have a good answer to that, so you can argue in the setting of that maybe there isn't a role for monitoring. Okay, if you are going to monitor, so for therapy response, prealbumin levels, once again, don't really know what to do with it, but for what it's worth, as Dr. Alexander noted, prealbumin levels we expect to go up with stabilizer therapies. Which is somewhat counterintuitive when a patient first hears that, but it is. The more it rises, there is a correlation with better outcomes, but that doesn't mean we have a way of targeting higher prealbumin levels. If we think about disease progression markers, as was highlighted before, some ones you can think about, certainly heart failure hospitalizations, the outpatient diuretic intensification, biomarker progression, particularly with NT-proBNP, decrease in the EGFR, decrease in 6-minute walk test, and worsening of quality of life or functional status. So these are all progression markers. But is that truly progression of the amyloid disease, or is it heart failure progression due to, for example, the patient we had today, his development of atrial fibrillation? So what to do if a patient is progressing? The first thing is to not just say, well, your amyloid's getting worse, but to say, is there something else of which an arrhythmia, particularly atrial fibrillation, will be the most likely reason? Should you change therapies? We do not know the answer to that. So I think a lot of patients will be interested in changing therapies if they have been getting worse, either by one of these markers or they're simply feeling worse. And that's not unreasonable, but we also don't have evidence to say if you change therapies, you will do better.
So optimizing therapy access, of course, we are extremely lucky because we've got 3 very positive clinical trials, but ultimately, if patients don't access the treatment, it's like being back to 10 years ago. So ATTR therapies are incredibly costly. I mean, I think as clinicians, the only thing we care about is actually everyone who with ATTR amyloidosis get treatment. And we are all aware that this is not the case. There are insurance barriers, there are prior authorizations. I mean, I hear from my American colleagues the nightmares that they have to go through to actually get the authorizations in place for patients, and it can be extremely time-consuming and in some cases not successful. And there is, again, I hear huge coverage variation in terms of limited access. In the UK, we, at the National Disease Centre, we participated in all the clinical trials, and we've got probably one of the biggest centers of amyloidosis, but we got access to the families only a year ago. So until a year ago, in the UK, the only way for patients to access disease-modifying treatment was to take part into the clinical trial. Is this acceptable? Probably not. Disparities also increase among minority groups, especially Afro-Caribbeans. The paper that was shown in JAMA also about carriers versus non-carriers, how just having the genetic variants increase the risk of heart failure about 2.5 times, also showed the number of year loss lost by the Afro-Caribbean community over the course of time. And this is really not acceptable. All the adults on fixed incomes, again, in many countries this is an issue. They cannot have access to disease-modifying treatment, and there are regions with limited specialist centers where patients don't even get diagnosis, don't even get easily to a specialist center, or have to travel so long that actually for them it's not feasible, and so they never get access to disease-modifying treatment. So ultimately, we are in a field where disease-modifying treatment are available, but still we are very behind to make sure that every single patient can access this treatment. And this is something that we all have a duty to work on. What are the practical solutions? I mean, I'm afraid this is an attempt to say what the practical solutions are, but of course it's extremely complex. Streamline access, early liaison with pharmacy, benefits team, patient assistance programs and foundation support. We need to keep going with advocate for policy and value-based pricing, multidisciplinary access champions, and of course collect real data on access gaps. So we need to do more about research about where access treatment is missing. How many patients with ATTR cardiomyopathy don't have access to treatment? There's not a single study that gives us this information. And so we need to do much more about which are the patients that don't even have a chance ever in their life to access treatment, that still are dying of a progressive and fatal condition where disease-modifying treatments are available. So lots of questions mark, there are no easy solutions, but definitely we need to do much more, at least in raising the awareness of the gaps we have, of the millions of patients who don't have access to this treatment yet. So the last very quick point, so we all talk about multidisciplinary collaboration, and I'm extremely lucky because I work in a center where it's multidisciplinary by nature. Every Tuesday afternoon, we've got a 4-hour meeting from 9 to 1, where we've got cardiologists, hematologists, nephrologists, rheumatologists, people from histology and genetics, all sitting together for 4 hours. I know this might sound a bit, it's a long meeting, yes it is, but we discuss every single patient. We review all the images, all the biomarkers, clinical findings, we review together histology and genetics. And it's just an extraordinary experience. When people, they tell me, oh, how do you kind of increase your knowledge? Going to conferences, going to reading books, reading articles. Actually, for me, the most important kind of teaching experience for me is the Tuesday morning, where I hear my colleagues having a slightly different opinion from mine. Hematologists say, no, I don't think this way, we should change treatment. Nephrologists, rheumatologists, and seeing also the broad spectrum of all types of amyloidosis, not just TTR. And for patients, this is completely transformative because they get seen by one of us, but actually in the multidisciplinary settings, their case is being discussed by the different experts, and each of us can give input on the optimal management of every single patient. So I'm a strong believer that actually the multidisciplinary approach needs to be a key feature of centers which treat patients with all types of amyloidosis. Coordinating the patient journey is not easy. I'm not saying that the center is wonderful and everything, because it's not just discussing the cases, but it actually is the ongoing management. And that is definitely extremely complex. I think it's the next level of complexity where it's not just the input at diagnosis, but the ongoing care. And definitely there is a lot of work to do on how the different specialists integrate in the management of patients in what is a chronic and long life condition.
Okay, great. So we have about 8 minutes to take questions from the audience. So feel free to stand up and have your question. There's some that are on the online chat here, so we can go through those in the meantime while people think of questions. So maybe the first one I'll direct to Ron. So there's limited studies on the role of implantable defibrillators in patients with ATTR. And particularly now that patients are, the tendency is to diagnose them earlier, is there a role for defibrillators, and if so, which patients?
Yeah, it's a good question. I hate to be a broken record of we don't know, but we don't really know the answer to that. I would say in general, ATTR patients seem to be at pretty low rates of sudden death from ventricular arrhythmias. AL patients are at much higher risk, and I'm much more inclined to place them for AL patients. So most of the time I would not for a TTR patient. Somebody with a very low ejection fraction is probably at higher risk. If you have somebody where, for one reason or the other, you've done ambulatory telemetry and they're just having tons of NSVT, sure, you can use your judgment. But in general, they're at very high rate for heart block, but pretty low risk of ventricular arrhythmia-related sudden death.
Yeah, totally agree. So this is another device-related question, maybe for Mariana. So what's the role for biventricular pacing in patients with ATTR, particularly if they have a bundle branch block?
I mean, I'm sorry to hear again that we do not have an answer to that. What we do clinically, depending a lot on what within the NHS we can do in the different kind of regions, because and again, it's based on the patient situations, but for patients like, is it the patient going to be paced all the time? So are we going to implant a patient who's going to be paced 100% of the time? In those patients, we try to implant a biventricular device, even though there's absolutely no evidence that that is better than actually other kind of approaches. So how are we going to solve that? I'm not sure that ever a trial will be an answer in these patients. I personally, we discuss every case, and again, it depends on how frequently the patient is going to be paced, and also the AV block as well, because I am not fully convinced that we should leave, for example, a patient asymptomatic with 350 or 400 PR, because at that time, the AV coupling is completely gone. And we know that actually atrial contraction contributes to 25% of the ventricular filling. So I think in terms of pacing, there are lots of questions. Is RV pacing versus biventricular pacing, but also AV coupling often in these patients with very long PR is completely gone. So is it more important to optimize the AV pacing? Is it more important to optimize the biventricular pacing? These are all unanswered questions, and I don't think that there is any guidance on what's the best choice at present, but I don't know if Monish.
Yeah, I mean, I agree. I would say if for patients who are being paced all the time, we would pretty much always go towards IV pacing. I mean, the data out there is basically biomarker data that people seem to do better if you upgrade them, but nothing strong data. But I agree, we're probably not going to get better. But if your patient can be paced all the time, I would. Whether or not a patient with a QRS of 145 milliseconds with a just nonspecific delay who doesn't otherwise need a device should get a BIV, that I'd probably be more skeptical of.
Yeah.
And one of the questions also that we ask ourselves very often, when we just put a kind of backup pacing, probably we shouldn't leave this patient at 50, 55 in the sense the pacing threshold in terms of heart rate probably should be higher, because we know that these patients, the only way they have to increase the cardiac output is actually through heart rate. So there is also a lot to do in terms of how do we program the pacemaker in these patients, which is probably very different from what we would do in general heart failure.
Yeah, I completely agree. I mean, I guess that would be kind of a third pillar for management: disease-modifying therapy, heart failure management, and then rhythm. Yep. And a lot of times you can go up on the backup pacing to 70 or 80, and that can have immediate benefit for patients. So I think sometimes that gets overlooked. Maybe this is a question for all three of us we can comment on. So kind of a question around how to diagnose and manage and treat ATTR in resource-limited areas such as Uganda. So I think this could apply to a lot of areas outside of Europe and the U.S. So I guess any advice that you guys have for those?
Well, Palo Alto is not exactly Uganda, but I would say, so yeah, we're privileged in this country where we have access to all three approved therapies, and it takes some doing sometimes, but we can pretty much get everybody on a therapy. I think with resource-limited settings, a couple things. One is there are still things that can be done, as have been highlighted, independent of the ATTR-specific therapy. So rhythm management, if you have access to SGLT2 inhibitors, MRAs, those are things that can be done. In terms of what to do, I again, not practicing in such a setting, I don't imagine that I can give advice as somebody who is practicing in such a setting can. The only thing I would say is these therapies do make a massive difference. And if you compare the impact of these therapies on outcomes to, say, our standard HFrEF or HFpEF therapies in the big clinical trials of carvedilol or SGLT2 inhibitors or ARNIs, there's a much bigger treatment effect, a smaller number needed to treat with all of our ATTR amyloid specific therapies. So to the extent one is able to, you really want to try to, but I understand that in some parts of the world that's just impossible.
I mean, I think it would be quite nice to start from data, because I have no idea how many patients are actually not having access to disease-modifying treatment worldwide. So I would love to see, I don't know, a paper that actually give numbers across the different continents and show disparities. I think showing the gap, the size, the magnitude, the number of patients, how this is also different across different ethnicities, because I'm sure that that is going to be minorities will be definitely in the areas with less access. I think it would be a very first important step to try to do something about it.
Yeah, I mean, I guess two things I would say are, the piece of access to disease-modifying therapies, I think, is a bigger thing, and hopefully we can work with our pharma colleagues to get drug into these lower-sourced areas. But in terms of how to diagnose and manage patients, I think there's a lot of education that can be done, similar to what we've done in the US and places outside of amyloid centers. A lot of places have some of the resources to do scintigraphy, for example, but don't have the expertise yet to interpret it. And I think that that's where, particularly with virtual, teleconferencing, it's easy to do multidisciplinary kind of joint meetings with, other physicians and review cases. And I think that once you see a few patients, the uptake and understanding of how to diagnose and management goes up, rapidly. The learning curve is steep. So, a few years ago, I did a talk with a couple of colleagues from Harvard in South Africa, and, it was a couple of days of reviewing ATTR cases. And, by the end of it, already gone through a lot of the nuance of different clinical scenarios, and their diagnosis rates, steadily increased after that. So, I don't think it solves everything, but I think that's one thing that we can do on the medical side. So it looks like we're at time. So if there are no questions from the audience, thanks for joining us, and happy to chat with folks afterwards. And then here's the QR for CME. Thanks.